Okay, this video is going to be probably of minimal interest to most people other than myself. It's about CAR T cell therapy, which is a pretty esoteric thing that most people outside of cancer immunology are not super interested in. But I've been kind of peripherally following it. Let's see, sorry about that. Peripherally following it um, because I've heard about it for the past decade or so, but never really looked very much into it because CAR T cell therapy is not very successful in solid tumors. And professionally, I mainly deal with solid tumors because I'm a surgical oncologist. But earlier this month, there was a paper published in Nature talking about decade-long leukemia remission with persistence of CD4 positive CAR T cells in patients. So these are patients that achieved remission of their chronic lymphocytic leukemia through a CD19 directed CAR T cell. CAR stands for chimeric antigen receptor T cells in 2010. And what's interesting is not only has their cancer not recurred in over a decade, but when they check the patient's blood, the patients still have these CAR T cells circulating in the blood. So theoretically, it's possible that these cells are still constantly fighting any kind of flare-ups of the cancer and knocking it down. So because this was it's a very impressive thing to one, have complete remission over a decade later, and two, to still have the therapeutic agent circulating around in the body. That's amazing. Um, and so I looked into a few papers about CAR T cell therapy to try to educate myself on it, and this is what I found out. So CAR T cell therapy is basically what they do is they take T cells, they extract each patient's blood and extract the T cells from their blood, and then they modify these T cells. They basically use a viral vector or some lipid nanoparticle or other transfection mechanism to insert a synthetically designed receptor into the T cell. And now, most T cells, if you remember from my immunology video a few months back, most T cells have what's called a TCR, or a T cell receptor, which looks very much like an antibody. And this TCR determines what antigen the T cell will target. And the difference between the TCR and this chimeric antigen receptor is that this TCR requires a co-stimulatory molecule, a different receptor, to attach to the HLA of the target cell. So like a cell has to present antigen to it, so an antigen presenting cell can present it, and they'll present also their MHC complex. And the TCR will bind the antigen, and then the co-stimulatory molecule will bind the MHC or the HLA determinants. And then that you require both to activate the T cell. The chimeric antigen receptor actually is like a TCR, but it's got the activation molecule on the intracellular side of it. So it doesn't require, it's not HLA restricted and it's not MHC restricted. So it's going to just activate when it binds. And so initially they just had a single activation domain, but now you can have multiple activation domains so that you activate the T cell even more effectively. Now the downside, so there have been many things tried where they target B cell malignancies, renal cell carcinoma. Interestingly, I saw this EGF V3, and that is a truncated form of EGFR. Did a little research on that during my fellowship, and then they're targeting MAGE and a bunch of other solid tumors. These have not been very successful in solid tumors, but they've had great success in leukemias and blood-borne tumors. Because I guess and it's unclear why they don't work so well on solid tumors. But in a way to think about this is that CAR T cells are kind of like monoclonal antibodies. So monoclonal antibodies target a specific cancer antigen, and then it activates a bunch of the antibody-mediated processes. However, monoclonal antibodies, they disappear after you infuse them. You just get them once. The difference of these is that this is like a living drug. It's your own T cells. They modify it, they grow it up, and they give it back to you. And then these T cells replicate in your body, and they continuously make more of themselves. So you don't have to get it reinfused. The difficulty of this, obviously, is that every person has to have an individualized drug for them, because you can't take like my T cells, modify my T cells, and give them to you, because then they would attack your body. So every patient has to have their own T cells removed, their own T cells modified, then grown up, and then reinfused them, which is very expensive, as you can imagine, and very labor intensive. But if it works, cancer therapy is labor intensive and expensive no matter what. So it's very fascinating that it's basically you're creating a monoclonal antibody that has a stimulatory mechanism on the intracellular domain, and then you transfect this into the patient's own T cells, and now you can give the T cells back to them, and the T cells will replicate. And as this paper finds out, you can have these T cells that are directed against the cancer still surviving over a decade later, and possibly still working and keeping the disease at bay. So yeah, it's very fascinating, and read 3 papers, and I thought I'd make a quick video, and mainly for myself, and mainly so I can keep track of these references so I can go back to them when I forget how it worked, which I will in a few months.